I apologize, my slides are not fancy. I had technical difficulties. Okay, so Breech presentation. They're frank, complete, and footling, you see there. And then when you get closer to term, there's an incidence of about 3 to 4%. So let's see. Who's our intern here? We have two. Hillary? Okay. So if you are in clinic and you're seeing your OB patient, when would you check for fetal position? After 34, okay. And then let's say the baby is breech. What would you do?
Counsel them on a breech presentation at the time of labor, but also that they may turn and counsel them on an option.
Okay. Carolina, what do you think? When would you check in clinic for fetal presentation? Your routine prenatal care.
I said checking in the third trimester just like obviously.
Okay.
The afternoon, but probably starting around 34, 35 weeks.
Okay. And then so you do a Leopold or you do ultrasound?
I do Leopold. Sometimes if I think, if the family is very healthy, there's diabetes or other studies, I'll do. If I'm not sure, I'll just do just a abdominal scan.
Okay. Okay. And then Natalie, so let's say she is breech, you confirmed it at 35 weeks, because that's when they're checking. And so you counsel the patient, you're talking about what are her options?
So I think like part of the thinking is around checking around 35 weeks if you want to give yourself time for the optimal period for a synol version, which is around 37 weeks. So in counseling her, I'd say if you're wanting, maybe is the base of the direction that's most amenable to a vaginal delivery, there are options to try and turn the baby in order to make it possible for you to have a vaginal delivery because we don't agree vaginal delivery institution. You need to start planning for that in the next couple of weeks. Or your other option is, we'll recheck and see if baby turns on their own, but if not, C-section for breech.
Okay, and when would you schedule a C-section for breech? If she declined a version or if your version was unsuccessful? 39 weeks, yeah. Okay, good. So generally I will check for fetal position around 36 weeks. I'll just bring in the ultrasound and just take a look. Leopold's is not perfect, especially if the patient is obese. And generally, like, when do you see, Ari, when do you see versions scheduled on labor and delivery? 37, 38. Why not earlier if the baby's smaller and the chance of a successful version is better when baby's like smaller?
Because they have a higher risk of turning again and becoming breech again, and you have to be prepared for an emergency C-section, and the benefits do not, the risks outweigh the benefits under 37.
Right, so you would be possibly delivering a preterm baby, right? So, right, okay, good. So, okay, another, oh, sorry, yeah?
Quick question, for those of us who are remote, if you could just summarize an answer or repeat a question so that everybody can hear you. Thanks.
Oh, okay. So basically, it sounds like for routine prenatal care, the residents would check for fetal position around 34 to 36 weeks by Leopold, or they can do an ultrasound. And if baby is breech, they would counsel the patient that the baby could turn, but if stays breech or malpositioned, there's the option of scheduling an external cephalic version. And here we do it after 37 weeks with, because the thought is that when you do the version, there's a risk of delivery and you want to avoid a preterm delivery. or schedule a C-section at 39 weeks if they decline version or the version is unsuccessful. And I'm going to get into all the nitty-gritty later. So here's the transverse lie, and then face presentation is another one. Have any of you delivered face presentation? I know Dr. Cologne did one last year. I can't remember with which resident, but basically you could deliver vaginally face presentation, but it depends which way the chin is. So where should the chin be? Anterior, so it fits under that arch, right? Right. Okay, so we talked about diagnosis of fetal presentation. You could do Leopold's, ultrasound. It could be seen on x-ray. We don't really do that. So what are factors contributing to malpresentation? Don't read. Yes, multiple. What else? Uterine anomalies. What else in the uterus? Fibroids, good. Uh-huh. Fetal anomaly, sure. Uh-huh. Poly, right, good. There's a lot of room to flip around. Abnormal presentation. Huh? What? Oh, pelvic shape, sure, yep. And, okay, so counseling we already talked about. So it should be shared decision-making with the patient. You know, basically talking about, you know, risks to the baby, risks to the mom. So your options, as we said, was external cephalic version, cesarean section. Technically, she could do a vaginal breech delivery. We don't usually offer singleton vaginal breech deliveries because of what is the risk? What are the risks that we are concerned about? Head entrapment, right? And then lack of oxygen to the baby, brain injury, etc. And we can talk more about what you would do. But let's say if she comes in completely dilated and like the legs and body are hanging out and she doesn't want a C-section, yeah. So then you would, you know, obviously you can't do a C-section on her because that's battery, right? So you would do a vaginal breech delivery. Okay. So ECV, so success rate, depending on who you talk to and how much experience they have, about 50%. One study quotes up to about 65%. So without looking at the screen, what factors decrease your chance of a successful version? Big baby, anterior placenta, obesity, good. Definitely provider dependent. Poor pain control, yep. NOLIP, okay. So based on these studies, they say to offer versions around 36 to 37 weeks. There's no upper limit of when you can try. It's just not going to be as successful the further along you go and the bigger the baby is. And spontaneous rate of reversion is about 16% with the pretermers. And after 37 weeks, the success rate falls, but the reversion also decreases to about 6 to 7%. Okay, so contraindications, multiple gestation. I mean, you don't want to do twin A. It's a different story. If you have delivered twin A and then twin B is non-vertex, you can try to vert the baby. Any reason why, or any reason for the patient not being able to deliver vaginally anyway? Like if she has a previa and she can't deliver vaginally anyway, what's the point of verting her, right? If there's signs of placental abruption, bleeding in the last week, any, you know, uterine anomalies, fetal anomalies like hydrocephalus, IUGR, severe oligo. Can a patient with a prior section, one prior section who wants to VBAC have a version? Yes. Yes. One prior C-section who wants to TOLAC. Can the patient have a version? Yes. Yes. So 2 prior, maybe not. Okay, and then active labor, rupture of membranes, morbid obesity, you would want to avoid. Let's see, and then, well, we talked about you could do ECV on the second twin. Okay. So why you want to convince your patients to try for aversion. It can reduce, so it reduces the rates of cesarean deliveries with no significant maternal or fetal complications. In terms of pain control, like one of the things that you guys mentioned is, pain. Do we usually do epidurals or spinals for versions? You can, right. Sometimes it's just kind of the logistics. Usually we're trying to do it in triage, and then we want to either, send them home and then come back if they are, if it's successful and then come back in labor, or if it's unsuccessful, they go home and come back for a scheduled C-section. So one of the things, if they have better pain control, then you can do the maneuvers for longer. You could be a little bit more aggressive. Some people worry that maybe then you might be too aggressive and then cause more complications because you don't have the patient kind of telling you to, hold off or stop. But there was a study that shows that that having anesthesia does increase the success rate from 37 to about 60%. And then also, important, we have anesthesia in-house. We have the ability to do a stat section here. So we don't really think about that, but if you were to go to private practice, you would want to make sure that you're only doing it in a place where you can do stat section. Huh? You were verted in the clinic?
My sister was verted in the clinic. I was verted at home.
Oh, by yourself?
Yeah, my mom, my great grandma did it.
Oh my gosh. Whoa. Now, what else could you, okay.
My grandma was a midwife in India, so she helped my mom birth me at like.
Oh, Ray saying her grandmother was a midwife in India and birthed her baby at home.
Ray.
Oh, birthed you. Oh, you. Okay. I was like, oh my gosh. So what is the other thing you have heard of that could make that is kind of an alternative therapy that could encourage the baby to turn? So you're like burning something by the foot, by the fifth toe. Have you heard of Malpresentation? You've not heard of this? So you burn. Yeah, you burn this like, yes, you put it on like the fifth toe, you burn this like, yes, some kind of incense or leaf or herbal something, and it's supposed to encourage the baby to turn. Malpresentation. M-O-X. Oh, no. Mom's toe. Okay. All right, continuing. So your ECV checklist. So first of all, you need to counsel the patient and get consent. You want to discuss the risks, right, which you guys have talked about, PPROM, preterm labor, non-reassuring fetal heart tracing or D cells, placental abruption, need for emergency C-section, maternal pain, reversion to breech, or just it's not successful. Benefits avoiding C-section, cost effectiveness. One study estimates that you'd save $1,500. And we talked about performing it at a place where you can perform an emergency C-section, anesthesia is available. She needs IV access. We do an NST before. We make sure she's NPO in case of C-section. And then terbutaline. So do you guys order terbutulines sub-Q or IM, or does it matter? And then how many minutes before version do you want the terbutaline on board? Natalie, because you made eye contact with me.
No, I like remember, I thought it was with you that maybe it was, but, so I think you did it like 15 minutes before, and the difference between getting IM and sub-Q is that you IV versus IV. I think you generally have.
Oh, sorry, I put IM on there. IV is meant to be IV, yeah.
Greater chance of like having the tachycardia maybe in the IV as opposed to sub-Q. I'm trying to remember because I remember it being a discussion. That's my guess.
Anyone else?
Sub-Q 15 minutes.
Yeah. Generally it's sub-Q, but there was a study that, and sorry, I put on their IM, I meant IV, that there is no difference in outcome ultimately. So either's fine. Pain control we talked about, and then if she's Rh negative, you do want to give Rogan because there's a 4% chance of fetal maternal hemorrhage. And then you also want ultrasound available at the bedside, and you should be checking fetal heart rate, right? Because you have the TOCO, you have all the monitors off so that you can do your maneuver. So just put the ultrasound on there to check the heart rate and also, you know, how much progress you're getting in terms of the fetal position, at least every 5 minutes. Okay, so the maneuvers, let's see. It's all written on here, but Mia, how do you perform your versions?
With prayer. And generally what I try to do is to elevate the bottom out of the pelvis.
Okay, elevate the bottom out of the pelvis.
And then I would try one direction, and then if that's ready to try the other direction. But usually you try with the direction that the baby is facing so that the rotation is a little smoother, possibly.
So try rolling the baby the direction that the baby is already facing and the shortest distance, maybe. Okay. And then so you have one hand on the butt, and then the other hand where?
Maybe at the head or behind the head.
Okay, behind the head, good. And then do you do steady? Do you rock? Like what is your take?
I do steady, and then you have to basically gain ground every inch that the baby is going. So you follow the rotation both with your other hand and the hand that's behind the head, to try to hold it in place as you're attempting the version.
Right. So steady. Sometimes I find initially I learned a technique, a little bit of rocking. I don't know, somehow it just kind of dislodges it, and then once you get into a good position, it may smoothly come down. And then if it doesn't work in your forward roll, you can try backwards roll. You can have someone else try. And then basically you can keep doing it as long as the fetal heart tracing looks reassuring. But if the patient's in a lot of pain, the fetal heart tracing doesn't look good, or you've been at it for a while and it's just not happening, then that's when you would call it quits. So putting the patient in a little bit of T-birth might also help elevate. So I know, like, when we do it, we're doing it together, and sometimes, someone says, okay, I'll elevate the bottom and then you can do the head. Personally, I find it difficult to have two people do it because you're kind of fighting each other. You're not really moving together. It's almost better to just do it yourself. One hand elevate the bottom and then the other hand behind the head. And then once the bottom is like out of the pelvis, like maybe the baby's like oblique or transverse, then maybe two people can work together. Okay. All right, and then afterwards you want to do a non-stress test, right, to make sure that the baby looks okay. Some people describe letting the patient walk for 15 or 20 minutes and rescan to see if still vertex. You could, if she's close to 39 weeks, you could just admit for induction for unstable lie, or just have her come back when she's in labor. What other tricks have you seen people do to try and keep the baby down? Strap it down, right? So you could like tie a sheet or something. I had an attending put abdominal binder on a patient.
Yeah, they could have this like roll blankets or roll towels on either side like this. It's just to kind of put pressure. And then an abdominal binder over this.
Yeah.
And then there's this like, I can't see here.
So if you had an unsuccessful ECV and then you schedule her for C-section, you could offer her another attempt of an ECV after she gets her spinal. And if it's successful, great, keep her to induce. If it's not successful, then go ahead with the C-section. So that's one more option.
When you say under spinal, does that mean like
they actually place an epidural just in case she gets actually successful and she has an epidural.
Oh yeah, you could do an epidural. Yeah, yeah. Either or. Okay. So breech delivery maneuver. So vaginal, it's going to be very similar, whether it's vaginal or C-section in general. So definitely you want a provider who is experienced with doing them, and ideally someone who actually knows how to use Piper forceps. What are the Pipers used for? Breech of the after coming head, right? Okay. And then you do want a second provider available, right? It's going to be, you're going to need 2 providers for delivering the head. You need one person to help hold the body and then give your pressure to flex the head. You want peds NICU at delivery. You want to make sure the bladder is empty to make as much room as possible. And then consider an episiotomy if it would be helpful. But you don't have to do routine episiotomy. Okay. So it is important that she has to be able to push, okay? So you need to explain to the patient she has to be able to push. Ideally, you want good anesthesia. And then you want her to be able to push up until you can see the umbilicus. So you've delivered, let's say for the maneuvers, you would be delivering the sacrum anteriorly. Okay, so let's say breech, you've got the butt coming out, and then you want to rotate the sacrum anterior. So I just hook at the hip, like so. Let's say baby's like rotated like this. So you're gonna have her push, 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 and then you're gonna rotate. You're not pulling, you're just supporting. And then once you get to the level of the body,
They can't hear you.
You can't hear. Okay. Okay, sorry. So, once you, so if you're delivering, so you deliver the sacrum and the bottom, and then now to get the feet, right? There, what maneuvers do you do to get the feet?
You push behind the knee to flex.
So the Pinard maneuver, right? So you're gonna push in on the popliteal fossa behind, and then yeah, abduct and deliver the leg, and then do one on each side.
Similar to C-section.
So, very similar to the C-section. It's the same maneuver, right? So you're reaching up, and then you just want to make sure you're not externally rotating so much that you're gonna dislocate the hip. But similar to with the arm, when you're trying to get like the posterior arm, when you're pushing in the antecubital fossa of the posterior arm to pop like the hand up so you can deliver. That's kind of similar. Okay. Now to deliver the arms. So okay, you have your assistant supporting the weight of the baby, right? And then now you're going to deliver the arms. So Ray, can you describe how you deliver the arms? You're going to speak.
I mean, you kind of what you just said, you go for the posterior arm, with your finger with popliteal fossa, the antecubital fossa to deliver the arm. Well, you want to so first you want to rotate the baby so that you've got the baby anterior, posterior, or then deliver one arm and then rotate the other way to deliver the other arm.
Yes.
Sorry.
So I rotate the baby's body to, if I want to go for the right arm, I rotate so that the right arm is more anterior, okay? And then, like, if the arm is all the way up here by the face, like there's no hand to pull or anything, I just go behind the shoulder and hook around, and then you can find that, you can find your antecubital fossa and flex it to bring it down. Now, the important thing is that you want the arm to come across the front of the body, right? not like this because you're gonna like dislocate the shoulder, and it's like increasing the diameter. So you want to roll it across the front of the body and then bring it out. And then once you bring it out, then you can rotate to her other side, her left arm, and then repeat the same process. Okay. So I kind of think of it as like if the baby was swimming, right? Like that's kind of the motion that you want to make. Not backstroke. Okay.
Right.
All right.
Breaststroke.
So once the body is out, you're gonna elevate a little above the horizontal, but not too much because then you're gonna extend the neck too much. You want to have the head flex for delivery, right? So what? Let's see.
You want to go on that side?
Oh yeah. Oh, this is the talking about the forceps.
Okay.
So the Piper forceps we already talked about, but if you don't have to use Piper forceps. But what is the maneuver, Ari, that you can do to deliver the head in a flex position?
Screening.
Yes.
Middle smart something.
More.
Middle smart. Just kidding.
Middle smart is like
Smelly something. Smelly nose. I'm sorry, I don't know.
More so. Okay, now you made me forget too.
Ari's fault.
I just remember it sounds like smelly feet or something like that. So describe what you're doing though. You don't have to remember the name.
You are trying to flex the neck of the baby by using your index and middle finger on the, not on the chin, you want to be in the kind of like orbital.
Maxilla.
Yeah.
So yeah, try not to stick your finger in the baby's mouth.
Or, because then you're just opening.
You're just
the
opening
chin.
the mouth and you
You
can
don't wanna be
dislocate
in
the
the
jaw. You don't want to be in the eyes, obviously. Yes, good.
Yeah.
So, and then your assistant will be giving suprapubic pressure to get the head under the pubic bone, and you're flexing like so.
Yeah.
Okay.
So smelly bite.
Yes. More so smelly bite.
So smelly bite.
What
Yes.
do we do with sharp angle up as opposed to?
It's almost right.
It's much easier to keep.
Pretend you do like what?
You know, I mean, I always think it would be easier to keep the head flexed. Right? If
Uh-huh.
you're going this way, as
Yeah.
opposed to
Yeah,
this
yeah.
sharp angle.
Yeah. I don't lift it too much. Yeah. You're supposed to. And then if you ever were to use Pipers, you would just like basically the body is across the forceps. You know, like you see here, the baby, they wrap the baby in the towel, the body, and then it's just kind of along the handle there. Okay, so what do you do if you have a head entrapment? So the head stuck, huh? Yes, good. What, can you describe the Durson? Cut where? What o'clocks? Yes, upside down Mercedes, 10, 2, and 6. Good. Why not 3 and 9?
That's where the arteries are.
Yes, that's where the arteries are. You're going to get a lot of bleeding.
How 12 you're gonna get the bladder.
Right, and 12 you can get into the bladder.
How many centimeters are you cutting? Like a centimeter?
Those are baby.
Until, yeah, I mean, I think a centimeter is reasonable. Honestly, I have not had to do it, knock on wood, but I think a centimeter, you don't want to be, overly aggressive, but enough to get the head out. I mean, if you're going to do it, you need, do it. Just like if you're going to cut an episiotomy, cut a second, because you need it, and then you're going to repair it, basically. Okay.
Could you give natural or is that not helpful?
I think that at that point it's the cervix. I mean, possibly, but it's more of the cervix, and you really need like expulsive efforts too.
Yeah.
So, yeah. If you were in a C-section and you had impacted fetal head and you're having difficulty getting it out, and the uterus is tight, that would be a time to give like, nitro or terbutaline or something to relax the uterus and the hysterotomy so that you can get the baby out. Okay, and let's see, what was I gonna say? Oh, in a C-section, so these maneuvers, most of these maneuvers, you're gonna be doing in a C-section for breech delivery. So for me, I like a generous hysterotomy because you're gonna be doing all these maneuvers. So, make sure you just cut just a little bit more than you normally would for vertex. Okay. Oh, and then recently I had a little bit of difficulty with the delivery of a breech baby, and I figured out the problem in a C-section is that if you're pulling the baby, you want to pull the baby's body, or you're delivering the baby's body, you want it towards the mom's legs. So the problem is the problem is if you start pulling it off to the side, what happens? You're turning the head to the side. So delivering the head in a flex position, the assistant has trouble because you're like, basically the assistant is mashing on the, the side of the face and not on the back of the head to flex it to deliver like as you want. So just be cautious that you're not pulling the baby towards you. You're pulling it down in the midline. Okay. So briefly, breech delivery of twin B. So like we said, no version of twin A. We don't do that. Some studies suggest that breech delivery of fetus is less than 1,500 grams could be safe. But just be cautious. And then what do we usually consider when we're counseling patients in terms of like the fetal weights of twin A and twin B, and if they're concordant? B should be smaller than A, right? Yeah, because if A fits through, then you know that any baby that is at least the same size or smaller should be able to fit through, and you would be less concerned about head entrapment. But if they're both, vertex, you don't have to rapidly deliver twin B. You can kind of let it come down a little bit. But if you do wait too long, it might not be as successful. Okay. Oh, that's it. Any questions?
Will you send us your slides? Oh, yes. Thank you.
Okay.
I will circulate them if you send it to me.
Okay. Sounds good.
Okay, make sure.
Can you explain why that gentle angle upward works for the breech presentation? Like when you said, the head is.
Because you need rooms to do your maneuver.